So welcome. Today we're going to be talking about perimenopause and trying to make sense of the chaos a little bit. So again, for those of you who don't know me, I'm Dr. Miranda Naylor. I'm an osteopathic doctor, board certified in family medicine and functional medicine, and I specialize in women's health. The reason for that is that when I was in primary care in the past, and even during my family medicine training, I realized that there was a huge lack of proper care for women in medicine. You know, there were so few tools, so few answers to concerns that were particular to women. I also love that we go through all these incredible phases. And, you know, a woman in her 20s is not the same as a woman in her 50s. And we treat them, there's so many things that we can do differently and treat them differently to really optimize their health through every phase. So that's really what my passion is. And on that same note, that's why I'm talking about perimenopause today, because it's such an important phase in our life that unfortunately doesn't get a lot of screen time. You know, not a lot of people really are aware of it, or at least to the level that they really should be. I think it's really important that women are aware of it as early as possible, honestly, so that we can see the signs when it is coming on and know that we can get support if we're having really troublesome symptoms. So I see patients out of Encinitas, California at Solsari, and I also see patients virtually. And before I go even further too, I wanted to note, please stick around through the end of the presentation for those of you who are here live, because I will have a special offer for you. So I want to make sure I say that ahead of time to give you a little incentive to stick around. So this evening, we'll be talking about how to define perimenopause, some common symptoms, typical hormone patterns during this time, which can help us really make sense of things, different risk factors that come up, and the best options for testing. So we'll start with defining perimenopause. So the STRAW criteria were created by the Stages of Reproductive Aging workshop. Basically, they put together these criteria to help us define the premenopausal phase, perimenopause, and menopause. So the premenopausal phase is regular menstrual cycles ranging from 22 to 35 days. Now, this is to be said that not every woman has a regular menstrual cycle and might be having short or long periods or something else going on, but this is what a normal menstrual cycle should be. And then the perimenopause phase is defined as a change in cycle length of at least 7 days, either longer or shorter in either direction from baseline for at least 2 cycles. So that would be a woman who, if she typically has a typical 28-day cycle, and then suddenly for 2 cycles, she's having a 20-day cycle, then she would be in the perimenopause stage at that point. And then menopause is not having a period for at least 12 months. This, of course, you kind of have to deduce later. After 12 months, you can finally say, okay, yes, I've been in menopause for the past year, but that's really the strict definition of it. Now, I love this picture to just show that there are different stages of the transition as well. It's not like we're in a premenopausal stage and then we're perimenopause and then we're menopausal. It's really this progression that's happening. So perimenopause is initiated by a decrease in ovarian reserve, which are these immature egg cells that have the potential to ovulate in our ovaries. In the late reproductive phase, cycles are either regular or starting to become slightly irregular, and we can start to have a lower ovarian reserve in our ovaries. Then in the early menopausal transition, this is where we start to have that 7-day difference in cycles, either shorter or longer. Then in the late menopausal transition, cycles are at least 60 days apart, meaning this is going to be the woman who starts to have, 3 months between periods, 4 months, things can get really inconsistent. And then the early postmenopausal phase is we've had our final menstrual period, and then we're not having any more periods after that. So this is a picture of an ovary, just to sort of give some context of what a normal ovarian cycle is. I feel like it's helpful to talk about what's normal before we start talking about what's becomes abnormal in the perimenopausal phase. So we start here with these primary follicles which are basically like the ovarian reserve. These are immature egg cells, which have the potential to grow bigger and become an egg cell that can be ovulated. So in response to FSH, which is from our brain, or follicle stimulating hormone, these grow and mature. Oftentimes, several will be maturing at the same time. One becomes the dominant mature follicle, and that is the one, when the signal comes to ovulate, that's the one that ruptures, the follicle ruptures, the egg is released, and then that follicle turns into what's called the corpus luteum. This is what produces progesterone. So I feel like that's really helpful to know because this is the only thing that's creating progesterone. So if we're not ovulating, which starts to happen in perimenopause, then we don't have progesterone, and that can come with different symptoms. And as we head into perimenopause, as this ovarian reserve declines, FSH starts to rise in response to that. And the analogy I give is that usually FSH just has to whisper at our ovary, like, hey, pss, pss, you know, start to grow, start to create these larger egg cells, let's ovulate. And it just that's all it takes. When we're having a lower ovarian reserve and we're heading into perimenopause, all of a sudden it's like FSH has to scream like, hey, come on, let's get going, let's do this. And that can cause a lot of the symptoms that are coming up as well, or make sense of some of the patterns that are happening. So this is, again, a typical premenopausal menstrual cycle. You can see here, these are the hormones coming from our brain, particularly our anterior pituitary, that's telling our ovary, giving it the signals of what to do, kind of maintaining this regularity. That follicle stimulating hormone that I mentioned is here in green. You can see it comes up a little bit. And again, usually it's just that little bit of a whisper to get those egg cells to start maturing, goes up a little bit during ovulation and then steadies back out. Luteinizing hormone is generally pretty steady and low and just has this one big spike, which is what triggers ovulation. Estradiol, this is on the ovarian level. Estradiol, which is our main estrogen, is released by those egg cells that are maturing. So it should have sort of a steady climb throughout the follicular phase, which is that first half of our cycle. And then it drops off during ovulation when it gets that signal from LH. And then it goes up a little bit again. It is also produced by the corpus luteum. So it goes up a little bit again and then drops down before the period. Progesterone, as I mentioned, is pretty much flatlined until we ovulate. And then when we have that corpus luteum that develops, then we're having a nice progesterone level. And that goes until the corpus luteum degenerates about 10 to 14 days after it's created. And the drop in both those progesterone and estrogen are what cause menstruation. And that's when we get a period. Again, knowing these things, it might feel like going back to science class, but I feel like it's important because it can make sense of like, oh, hey, if I'm having mid-cycle spotting, maybe I'm having a big drop in estrogen or something like that. And you start to make sense of these things. Now, to head into perimenopause and the menstrual cycle that starts to occur here, I love these diagrams. These are in a study showing the estradiol levels and progesterone levels of different women in perimenopause. And you can see how erratic things are, not only in the timing of the different spikes of the hormones, but the different levels. There's so much variation from woman to woman. And even, these are different women, but when we do look at even the same woman's levels, it can be completely erratic. And largely, or at least one of the main reasons why this is what's called loop cycles or luteal out of phase cycles. Basically, because FSH is yelling and we're having this fast and furious response of the follicles, they're maturing at a much faster pace. We can have these more rapid, what they call recruitment waves that can start becoming out of sync with our normal cycle. So typically that's just happening in our follicular phase. It's being suppressed during the rest of our menstrual cycle from our other hormone levels. But during the perimenopause period, because it's happening so quickly and FSH isn't going down the way it normally would, we can start having these rapid recruitment waves and we can start having compounding estrogen levels. So again, the estrogens are produced by those follicles. And if this is happening at several different times, we can start having layering of the estrogen levels. So you can see here this picture this dotted line is this out of phase dominant follicle estrogen. So basically, this is showing that ovulation can happen even during the period, and you can start having even high estrogen symptoms at random times or unexpected times, like during the period. Another thing to note is during the perimenopause period, we aren't ovulating as regularly. So that can be another factor too, where we can have these big recruitments, but we're not actually ovulating. And so we're not getting, again, the normal feedback, like negative feedback that we would to stop these loops from happening. So to go again into some of the hormone patterns that are happening here. So ovarian reserve starts to decline. That's the first thing that happens. And this is just over time, our eggs start to be depleted, and that declines. And in response, anti-Mullerian hormone declines. Excuse me. Got a tickle. All right. So anti-Mullerian hormone is secreted by these follicles. It's used in, we'll often test for it when we're talking about fertility, because it's used as sort of like an indirect estimate of ovarian reserve. Of course, I'm going to lose my voice right now. What was I just saying? So it's not the best test, especially when we're talking about it for fertility. There are a lot of other factors that can lead to an abnormal AMH level. But in this context, yes, we do know that as ovarian reserve declines, our AMH naturally lowers, and then eventually gets to a certain point where we know that ovulation is going to be really inconsistent and fertility is really inconsistent. Then from there, as I mentioned, follicle stimulating hormone increases. And this usually happens about 3 to 4 years before the final period, to give some context. Then from there, LH or luteinizing hormone rises about 2 to 3 years before the final period. Estrogen, again, as I mentioned, could remain about the same, or it could rise initially before it is lowered in the postmenopausal period. And then progesterone slightly declines gradually in the years prior to the final period. And as I noted, it is not present at all if we're not ovulating. So that's why the progesterone levels can become very low overall, but also erratic. And then I liked this diagram to show kind of more of the long-term scheme of what's happening with our hormones. You can see in the premenopausal phase, we're having these nice, steady cycles of our hormones. And then in the perimenopausal phase, things get erratic. Our estrogen levels become much higher than they normally would, and eventually start being depleted. Progesterone can be low for long periods of time when we're not ovulating. So this can cause a lot of disruption and imbalance. And again, knowing these hormone patterns, I think is so helpful to me, for what I do and as I'm helping patients. I think it really makes sense of the symptoms they're having. And that's why I wanted to share it with you as well. Is like, if you are heading into perimenopause and trying to figure out why you're having symptoms when you're having them, I think it's really helpful to have that context to know, oh, okay, these are the symptoms that can go along with higher estrogen or the estrogen drops. So when does this affect women? A study out of New Zealand showed that about 20% of women at age of 40 were considered to be in the perimenopausal phase. And then, as I mentioned, ovulation becomes inconsistent. So about 3 years before the final period, about 70% of cycles are ovulatory. About 2 years before the final menstrual period, about 50% of cycles are ovulatory. And then in the final year before the last period, only about 22.8% of cycles are ovulatory. So we start to have more anovulatory cycles, meaning we haven't ovulated, but we're having bleeding episodes in this time. So some common symptoms of perimenopause. Some are somewhat non-specific, but things like fatigue, insomnia, very classic. Irregular cycle length, as I mentioned, oftentimes they become shorter before becoming longer. Irregular period consistency. So women can start having really heavy periods when they're ovulating, and then when they're not ovulating, they might have this, very light, easy period because it isn't actually an ovulatory period, and it's just sort of a withdrawal off of some of the hormones. Mood changes are very common during this time as well, either worsened PMS from those higher estrogens, but also depression is very common in the perimenopausal and menopausal phases. Those vasomotor symptoms are also really common: hot flashes, night sweats, and palpitations as well. So diagnosing perimenopause, diagnosis is on a clinical basis, meaning there's no one blood test that will tell you that you're in perimenopause. It's really looking at cycle length, looking at the symptoms, and putting it all together. When we're looking at symptoms, they can be very variable throughout a woman's cycle based on hormone levels and their fluctuation. So like I mentioned, it could be that we're having high estrogen symptoms, it could be that we're having low progesterone symptoms, or it could be that we're having this rapid drop off of estrogen, which is causing symptoms. Most women often aren't aware of the difference between ovulatory and anovulatory cycles until they know this. You all will be better prepared. But most women will say, well, yeah, I had this random period that didn't have any symptoms. It kind of caught me off guard. Or I'm having these terrible, like, I'm inconsistently having really heavy periods or really light periods. And this can be why. So it can help make sense of things by knowing, okay, maybe looking for PMS symptoms when we've ovulated, like breast tenderness, irritability, bloating, versus looking for perimenopause symptoms like hot flashes, low mood, and insomnia. And the symptoms of perimenopause can affect each other as well. So not surprisingly, if you're having terrible hot flashes at night, you're not going to sleep as well. And then the next day you might feel a lot more tired or depressed. But also studies have shown that women who are at greater risk of worsened symptoms in one category will also have worsened symptoms in another category. And there are predisposing factors to having worse symptoms and having higher risks. So some of the predisposing factors include hormone levels, as well as hormone sensitivity. So that the difference there would be if you're predisposed to estrogen dominance, for example, or if you're just in a picture of being sensitive to hormones. Some women have a lot of sensitivity to estrogen levels or progesterone levels. Previous depression or insomnia, which is maybe not surprising if someone already has a hard time sleeping and then they're hit with perimenopause, that woman is going to be more likely to have a harder time sleeping in perimenopause. High stress is another big factor. And of course, we can kind of blame stress for a lot of things, but it has been shown that it is a compounding factor for worsened perimenopause symptoms. And interestingly, phthalate exposure also increases the risk of poor outcomes. Phthalates are a type of chemical that are found in a lot of conventional products, particularly in fragrance. So anything that has fragrance, even if it says natural fragrance, more often than not, it's a phthalate. And these are endocrine disrupting chemicals. And it has been shown that higher phthalate exposure is associated with, worsened vasomotor symptoms, which are the hot flashes and night sweats, and even cardiovascular disease. So good thing to note that even our toxin exposures can absolutely play a part here. So tracking cycles. I'd love to see here, just to sort of break things up in the chat. Let me know, do you track your cycles? Are you familiar with tracking cycles? I'd love to know, who's familiar with this, if this is new to anyone. But I think that Joy says, yes, awesome. Love to hear it. So someone says in menopause now, but did track. Awesome. It probably helped to know what was going on with your cycle. I find it so helpful for a lot of different reasons. I mean, just women just being able to know their menstrual cycle. And then again, during this time when we're having these erratic patterns, it can really help make sense of like, oh, hey, it looks like that was an anovulatory cycle. No wonder I'm having these, perimenopausal symptoms versus PMS. And as we're treating things, it gives me a lot of information as well to know, oh yeah, it looked like your temperature didn't rise, for example. It looks like it was anovulatory. We can give you a different kind of support in that context versus another. So it can be really helpful. Some things to also be aware of. So PMS will not occur in anovulatory cycles. So again, that would be like, all of a sudden I had this really easy period. It just caught me by surprise. That would likely be an anovulatory cycle or an anovulatory bleed. And then perimenopausal symptoms often arrive during periods of lower estrogen. Typically, that would be a few days before the period through a few days into the period, or more typically where we'll see perimenopausal symptoms. And there could also be more consistent regular symptoms that are going on that are then worsened in longer periods of amenorrhea or those longer periods without a period. So that can help kind of make sense of things. Yes. I'm just reading some of the comments. So it started with night sweats, hot flashes, and now not sleeping well and missing periods for months on and off. Yep, you are right there in it. Well, hopefully this will help make sense of things a little bit. All right. So to go into some health risks that come up during perimenopause and menopause. So bone loss, this is one that's maybe not surprising. As our estrogen's lower, we can start having osteopenia or osteoporosis. Cardiovascular disease, this is actually a really big one that if we address things early as possible, we can decrease our risk of. So, risk increases as FSH increases, meaning that as we're going through that progression and FSH continues to rise, then we're having more and more risk until the postmenopausal phase, which it stays fairly consistent. Women with PCOS may not get as much protection from treatment as for cardiovascular disease, meaning another woman might have decreased cardiovascular risk with HRT or hormone replacement, but a woman with PCOS might not have quite as much cardiovascular protection from the hormones alone. So it's good to be aware of so that, again, we can treat them differently and put them into different contexts to really customize things to that woman. Low thyroid function as well also increases cardiovascular disease, particularly a TSH of greater than 2.5 has been shown to increase risk a bit. There are also risks of cognitive changes that go along again with the lower estrogens, metabolic syndrome, which is characterized by insulin resistance, weight gain often, elevated blood pressure, elevated triglycerides, as well as sort of random seeming things like carpal tunnel, dry eyes, and decreased kidney function. They have been correlated in the literature with perimenopause. So I wanted to break things up again and show a case study here of one of my patients. We'll call her Jessica. So she was a 52-year-old female who came in to see me because she felt like crap. She felt like she had aged 10 years in 2 years, and she wanted to know what the heck was going on. She was fatigued. She had gained 20 pounds without changing her diet or doing anything differently. She had terrible brain fog. She couldn't exercise because it just wiped her out. She had terrible mood, was feeling really irritable and just down, and was having hot flashes as well. She had high stress at work. She also had a history of endometriosis and fibrocystic breasts, which are associated with estrogen dominance type symptoms or issues. And she also had a history of PCOS. So that will, I hope, just gives you a little context as we go into testing, then we'll revisit her case. So to talk a little bit about testing, there are different ways to test hormones. And I think it's good to be aware of the different types and the different advantages they have. So blood testing is the most common. It's very reliable. It's often less expensive because it's so routine, but it is limited in that it's one snapshot, meaning it is your hormone levels at that moment on that day, because hormones fluctuate very widely, even throughout daily cycles, monthly cycles. It can be very dependent, like when we're catching it, it can be harder doing things through blood. There's also a saliva test, which is mostly really reliable. It's easier to measure because you're just spitting in a tube. And it's a lot easier to measure throughout the day and the month if needed. So we can start having more frequent time points to get more information. There's also urine testing. In general, it's less reliable for a lot of the hormones, but it's also a lot easier. And it's the only way to measure metabolites of estrogen. These are basically estrogens that are broken down by the liver, and there are certain types of estrogen metabolites that are more dangerous or more protective as far as risks like breast cancer. So it is a nice thing to look at, especially when we're in a phase of having higher estrogens. When to test sex hormones. So usually, especially when we're talking about doing blood testing, we'll usually test them on day 3 of the cycle or day 21. The reason that that's in quotes is because not every woman has a perfect 28-day cycle. So really day 21 cycle, day 21 testing should be ideally 7 days after ovulation, maybe 7 to 10 days after ovulation. And the goal of that is to catch peak estrogen and progesterone levels after ovulation. Now, this, again, it makes it challenging when women have different lengths of cycles already in the pre-menopausal phase, but especially in perimenopause, this becomes a lot more challenging because we oftentimes don't know what we're catching when. So that's why it can be helpful to do some different types of testing. I want to give some context. This is some typical testing that I'll order on a woman who's coming in to see me with perimenopause, or even without perimenopause, because it's so helpful to get this comprehensive look, especially when we're in this time of higher risk of things like cardiovascular disease, metabolic syndrome. I find it so important to really look at the whole picture, and not just treat the hormones, the thyroid. We're really looking at the whole person. And so taking all of that into context. And a lot of these things can play a big part. So even things like vitamin D levels have been shown to have a really big impact on our mood, iron levels as well. So taking all of these into context, I think, is really important. And then here's an example of some specialty testing or functional testing that can be really helpful when we're trying to figure out what's going on. So this is a Dutch test, which some of you might be familiar with. This is basically a way to look at hormones through a different lens, be able to get a little bit more information. So these are some of the sex hormone levels like estradiol, progesterone, testosterone. It's sort of like a dial where you're seeing this is over the limit, this is under the limit. We can also look at cortisol patterns, which I'm not talking about much in the context of this talk, but can also play a part with things. And we can see a daily pattern of what's going on. We can kind of get more points in these, hormones are not just standalone, it's a cascade that they're, one is converted into another one. And so we can get more information about these pathways rather than just hormone levels. We can also see what I mentioned, these estrogen metabolites. So you see that estrogens are turned into these different types of estrogen metabolites. And some are more concerning, like for hydroxyestrone versus 2-hydroxyestrone, which it has more protective effect. So again, when we're seeing a woman with higher estrogens, either before perimenopause, during perimenopause, it can be helpful to see, okay, what is your body doing with the estrogens? And is it putting you at greater risk of something like breast cancer or other high estrogen issues? Dutch also has this amazing option called cycle mapping, where you can actually get more time points throughout the cycle to see what's going on with the hormones. And you can see here that we're getting kind of this curve, like we were looking at the other pictures, to be able to see, okay, what are your hormones doing throughout the cycle? And this can give us, again, a lot of information if we're trying to piece apart what's going on with your symptoms, how can we treat you best? Be helpful. And I wish I put a slide in here. I didn't put one in, but there are also more tests coming available that are direct to consumer, meaning you can just buy them yourselves. One that I've just started to look into is called Anito. And it's basically a little machine that you buy that you attach to your phone, and has little test strips, and allows you to actually test your hormones from home also. So I'm just starting to look into it. I haven't had a chance to really use it a lot, but I actually was just talking to a patient earlier today about it. She had done it, and I was like, this is really so helpful to be able to even do it from home, and it's a little bit less expensive. So stay tuned, check back in with me in the next month or so, and I might have a lot more to say about it. Because I think, again, I love tools that really give us more information and give women access to information about their health. So to go back to Jessica, so within a few visits, she was thinking more clearly. She had more energy, less bloating. Her periods had become more regular. as a result of treatment. We actually put her on cyclical progesterone, meaning progesterone at certain times of the cycle. And so her cycles became more regular and a little bit less erratic. Her hot flashes had lessened a lot. And she was feeling sharp, energetic, and she was happy. She's like, I feel great. Now, given, it's not always black and white. It isn't always the hormones. She had other things going on as well. She had some heavy metals actually going on as well. So that had played into how she was feeling also. But again, I think that's important to also note that it isn't ever just our hormones, just one thing going on. Oftentimes there are a lot of things going on. We're a human being that has a lot of complex things going on. And so looking at the whole person is really an important piece also to addressing not only the perimenopause symptoms, but someone's overall quality of life and their overall health. So with that, I will finish the lecture part of this and open it up to questions. And as you gather your questions and start typing them in the chat, I want to give you a special offer as a thank you for joining us this evening. And to make things a little bit more accessible to you, I want to offer 20% off your first visit. If you call within November, this month, by the end of November, and book an appointment at least by the end of January of 2023, then we'll give you 20% off. And the reason for this, again, I feel like money can be a barrier or a good excuse that we have for not addressing our health. So I want to take down that barrier a little bit and give you a little bit of incentive. If you're wondering about, oh, okay, I'm not feeling so great. I wonder if there is something going on, should I really address this? My answer is yes. And, just take this time to take care of yourself, consider it a Christmas present to yourself, and really a good investment in your health. Because again, with some of those health risks, the earlier we address them, the better in decreasing things like our cardiovascular risk, improving our bone health. So there really isn't time to waste. And it's not worth suffering, through these symptoms when you could be feeling a lot better now and improving your overall health for the future. So that is my spiel for you. And you can, here's our contact information here. So yes. So Nat asks, do you accept insurance? Great question. We are not able to accept insurance for office visits, but we can offer what's called a super bill, which is basically an invoice that has codes on it where you can request reimbursement from your insurance if you have a PPO. A lot of testing can be covered by insurance as well, particularly, routine blood work through a lab like Quest or LabCorp, and a lot of the functional tests that we use as well. We'll contract with insurance. Margaret asks, do you have any recommendations for liver support and proper estrogen metabolism when bioidentical estradiol, in addition to taking DIM? Great question. It depends a little bit on the context because there are different factors that can play into having an issue with detoxing extra estrogens. So one factor could be our gut microbiome. To not go into it too far, basically some microbes create something called beta-glucuronidase, which can mess with normal estrogen detoxification. And if that is high in a woman, number one, we'd want to address those gut bacteria and fix the problem at the root. But number two, we could also use things like calcium D-glucarate, which helps with that and prevents estrogens from being recycled into the body. You mentioned DIM, that helps kind of support the liver and getting rid of estrogens. There's also one called indole 3-carbinol, or I3C, which is similar to DIM in helping support that. And honestly, when it comes to detoxification in general, some of the basics go a long way, like making sure you're pooping regularly, making sure you're staying well hydrated, you're limiting things coming into your liver, like alcohol. That's another really common one. Alcoholism or heavier alcohol use is really common during the perimenopause phase. And it doesn't do a woman any favors because it can raise up those estrogens. It can mess with liver detoxification. So that can be another one, is just avoiding alcohol and taking good care of yourself, eating all of your broccoli and that. So let's see. Next question. How on earth am I going to have sex with hubby without the risk of getting pregnant if all my hormones and cycles are such chaos? This is a great question. So again, and maybe I didn't have it in one of the lecture slides, but yes, we can absolutely still get pregnant during this time. So it's important to have a conversation with your doctor about the best options for you, because if you are relying on cycle tracking for knowing when you're ovulating, it can get a little bit more complicated. And so if you're struggling with that, it's important to have a conversation with your doctor and see if something like oral contraception, like the birth control pill, starting to use a barrier method like condoms, what is going to best support you from preventing pregnancy. For women who still want to get pregnant during perimenopause, that's good news, because it means we absolutely can still get pregnant, into our 40s. Women often do. And so if that is their goal, then we could also support them in that goal. So yeah. Any thoughts on synthetic hormone medicine like T4? I hear it's mainly side effect free. So T4 is, if you're talking about like T4, like the thyroid hormone, that is usually called levothyroxine, is a typical synthetic T4, a synthetic hormone replacement that's thyroid hormone. That's kind of a different conversation. That's really for addressing thyroid, low thyroid function. And yes, thyroid function can play into this, so that it is an option. Natural desiccated thyroid hormones are also a great option for a lot of women. Depends. So if you do have a low TSH, low free thyroid hormones like free T4 and free T3, then that might be something to consider, repleting your hormones with either synthetic or natural hormone replacement. And then, you'd mentioned modified brand supplement. Any thoughts on this? So it's not one that I typically use. I think I have seen it, but it's not one that I have used. So typically the ones I'm recommending are professional grade, just because I know that they have really good quality measures as far as, they're doing third-party testing. The levels are what they say they are. So usually I stick with those. And then if there are products that we can't get through those companies, then I'll go outside of that. And it may be that they have good, but I just check with the company to see like what their quality standards are, and what their practices are. Great questions. Any other questions before we wrap up? All right. Well, again, reach out to us if you'd like to schedule an appointment. If you have any questions too, if you'd like to have a conversation about what we do, want to see if we're a good fit, we do offer free 15-minute visits called discovery calls, where we can chat and just talk about your case. And if we think that we'd get some good results for you or whatever. Will there be a replay of the presentation? Yes. So for after registering for this webinar, you'll get the replay sent to you, and you'll have access to that. So you can also replay it. So some of you are also watching the replay, and hopefully you're watching it within November and can take advantage of this as well. All right. Well, thank you so much for joining, everyone. I hope you all have a wonderful evening and happy holidays. Thank you so much for being with us. Take care.